promise I will explain why we have a cute bear and a robot on that first slide. So first, I want to acknowledge, after moving here, I think this is a very lovely way of starting a presentation, and I'm very grateful that our group and Prisma and our collaborators are located in Treaty 4, 6, and 7, and 8 territory lands, and all of these communities continue to influence our vibrant efforts here. So I'm very appreciative of that. I also don't have any conflicts of interest to report. And before I move on, I also want to make a quick comment about language. So like we've heard before from some of the other speakers, I will be using identity first and person first language interchangeably because of the preferences of the community that may reflect that diversity. And I will also be using some medical language and some social language interchangeably as well. Also because I think each of them have a role and we want to reconcile those views. So let's start thinking about the autisms and a way of understanding genetics and how we get to one of these diagnoses. So this is a helpful way of visualizing how we think of causality in autism. So we all have our jars, and depending on whether or not our jar is full to that threshold means whether or not we are going to be diagnosed with a condition or meet criteria for a condition such as autism. So in this particular case, we are going to have genetic and not genetic factors that are going to be filling this jar to different degrees. So as an example here, we have the purple balls that are partially filling that jar, and those would be common genetic variants that we all have. They are going to determine things like our height, and our eye color, and we all have one variation of these common genetic variants all throughout our genomes. Then we also have rare genetic variants, and these are, instead of being small balls that are filling our jar, these are going to be much larger marbles in there, like the magenta one shown in this image. So while you would need a lot of those common variants to fill that jar, maybe one of these magenta balls is going to be enough to get you towards that autism threshold. So much rarer in the general population, not everyone is going to have one of these rare genetic variants. And for people who do, they may increase the chances of developing one of these conditions. And then, of course, we have environmental factors that are going to be very relevant in regards to whether someone is going to be meeting a threshold for a diagnosis of autism or not. So this is just a recap of all of the components that go in place and how this is only one version of someone's jar. We could have many different ones where some people's jar would be almost entirely filled with environmental factors, or some others with only one of these rare genetic variants that's going to be enough to fill that jar. Perfect. And I think this is also a good point to bring up, that our goal, both in research, clinical care, and education, even if it sounds simple, I like to state that explicitly, and it is to make sure that everyone can be the best version of themselves that they can be, period. So all of these strategies that we'll be talking about is in order to empower and facilitate the accomplishment of those goals. Now let's go back to the drawing board and back to genetics. It's perfectly fine if you're already a genetic expert or if you only have basic genetics knowledge. Hopefully we'll be able to get some ground information started today. So we're talking about the magenta balls that we just saw. So these are rare genetic variants. Rare means that they happen in less than 1% of the population, and they can be in they can come in two different flavors, let's say. So they can be extra or missing chunks of DNA anywhere in our genome. So each and every one of our cells has all of our genetic information, and these genetic changes can happen anywhere in our genetic information. So we could have an extra or a missing chunk of genetic material, and we call those deletions if there's a region that's missing, or duplications if we have an extra region. And then in aggregate, both deletions and duplications are called copy number variants, or CNVs. So this is just to get all of our acronyms together. Then this would be akin to missing or extra paragraphs in a book that we're reading. Now, we could also have spelling changes in one of the words of those paragraphs. And those would be similar to single nucleotide variants, or SNVs. So these deletions or duplications may include a bunch of genes, a bunch of words, like a book, or they may include only one or two. But these single nucleotide variants are only going to affect one of the words or genes in our genome. And all of these are rare. And today we will be focusing on those genetic changes that are likely to have a large impact on people who have them. So why is this relevant? We know that autism is one of the neuropsychiatric conditions with the highest genetic basis, and that is evidenced by its high heritability. Now, heritability and heritable mean two very different things. It's very annoying that researchers sometimes like to complicate things, but heritability just means how strongly genetic something is. And that is calculated, let's say, looking at identical twins versus non-identical twins and seeing if they share a diagnosis or clinical features more often when compared to the non-identical twins. So by using that information, we know that autism has a strong genetic basis. And we also know that there are individually rare but collectively common causes of autism. So maybe we can do a quick show of hands for those of you here in person who has met at least 3 people on the autism spectrum. Yay, that's great. Now, who has met at least one person on the autism spectrum because of an underlying genetic variant? Okay, that's a great show of hands. And I was going to say that if you've met 3 people on the autism spectrum and you think you haven't seen one with a genetic variant as a cause for their autism, then they have certainly seen you. So the chances of us identifying a genetic change that is responsible and leading and explaining autism is up to 40%. So grossly 1 out of every 3 people on the autism spectrum is going to have one of these underlying genetic changes. What happens is that that large percentage is actually composed of many different rare genetic variants that come together. So none of those individually rare genetic variants, those CNVs and SNVs we were talking about, is going to account for more than 1 to 2% of cases. So this reflects that there's a lot of heterogeneity and overlap in both the genetic causes and the clinical presentations. We know that once you've met one person on the autism spectrum, you've met one person on the autism spectrum. That reflects that clinical heterogeneity, that differences in like we are all unique, and that similar heterogeneity is present at the genetic level. Now, sorry. The other piece that I want to highlight is that genes haven't really read the DSM or our diagnostic statistical manual. So they don't know that they're supposed to only cause autism or only be associated with certain neuropsychiatric condition. But we have instead this term called pleiotropy, which means that these rare genetic changes can lead to many different clinical features, both in the brain, in behavior, but potentially in other organ systems. And that cluster of clinical symptoms is going to vary based on those individual genetic changes. Now, this is also a good moment to underscore that autism is a clinical diagnosis based on observable characteristics of the people in the appointment, in the clinic, or in other settings. It is not a genetic diagnosis. And what this means is that you cannot use genetic testing to diagnose autism. That's not how it works. But we will talk about how you can leverage genetic testing to get a lot of really helpful information to help people on the autism spectrum who need our help. So again, you will not be able to diagnose autism with a genetic test, but genetic testing is a crucial part of the workup after a diagnosis of autism has been made. Now, this is a way of recapitulating some of that diversity and that heterogeneity. So this is what I like to call the autism umbrella. And everything under that autism umbrella is the universe of people on the autism spectrum. And we see that that umbrella has a shaded area in the background, and then there are all of these colored bars that are going to occupy some of that space under that shaded umbrella. What this means is that if we look at the universe of people on the autism spectrum, we would expect to identify several of these colored bars that each represent one of the well-known genetic conditions. And on purpose, I picked several of the most common and well-known ones. So we would have things like maybe Down syndrome, or hearing about a question earlier in the chat box about this. Or we would have something like Fragile X syndrome, and they are going to be occupying some space under that universe of the autism spectrum. And conversely, if you look at only those colored bars, then you can see that some of them are almost entirely under the autism umbrella, like Fragile X, and some of them are much more outside that autism umbrella, like Down syndrome. This means that if you start with a genetic diagnosis like this, then you have different chances of developing autism. And for example, a significant proportion of people with Fragile X syndrome are going to have autism, but a much smaller proportion of people with Down syndrome are going to have autism. But they are both going to contribute to the space under this autism umbrella, to the universe of people on the autism spectrum. So again, just a quick way of trying to understand that overlap and heterogeneity. Now, why is this relevant? Oops, I just moved from the US and I noticed that I left the US title in there, but these are Canadian numbers. So we know that our Canadian population is about 40 million and the Edmonton metro population is about 1.5 million, or 1.5 million and two, since me and my wife moved here a couple of months ago. And we also know that the population frequency of autism is up to 1 out of every 36 people. And we just were hearing that genetics can explain up to 40% of cases of autism, where we can expect to identify a rare genetic change. So by conservative estimates, this means that there's over 220,000 people in Canada with autism stemming from a genetic cause, and over 8,000 of them in the Edmonton metro area alone. So just think about that, about those numbers for a minute, and then allow me to put that into perspective, which is that there could be 3 times as many people with autism because of a genetic cause as there are people with HIV in Canada. So just think about the allocation of research and clinical and educational resources for something like HIV care. And now think about an equally sized population that is remaining mostly invisible because we are not necessarily doing the best job at doing genetic testing to identify those cases. So how are we going to address this challenge? We want to review first the recommendations for genetic testing. And because of everything that we mentioned, genetic testing for autism, specifically chromosomal microarray and Fragile X testing, is considered the first-line recommendation from multiple medical professional societies, including several here in Canada and in the US. Now, why should we do this? It has several reasons behind it. One is that it can provide an etiological explanation and end the diagnostic odyssey that many families go through. And we know that we hear often in the clinic that these are families that are going to one specialist and then another, and then their kiddos may have autism, but they may also have some GI issues or some heart problems. And then you're going to visits and visits, and now finally you would have a unifying reason for that cluster of clinical symptoms. It can also allow for better recurrence estimates and family planning so that families can make informed decisions that align with their values. It can also connect families with other families with the same rare genetic variant. And I like to compare this to now having a key to a secret door that you didn't even know was there before. And for many families who tell us that they feel very alone in this process, now they find a group of families that they can easily connect to online that are sharing some of their presenting symptoms and some of their struggles and some of their victories, and it's a very important source of support. And it can also alert us about potential medical co-occurring conditions. So we were reviewing the co-occurrence of maybe cardiac conditions and autism, or GI problems and autism in some people, and this would be the unifying link, meaning that it can also alert us about things that may develop that may not have yet been discovered clinically. And now, after reviewing those genetic tests, the recommendations are evolving to include exome sequencing as the first-year test after a diagnosis of autism or neurodevelopmental conditions is made. So this is a test that, unlike the other ones that we reviewed that are going to look for extra or missing chunks of DNA, this one reads all of the words or genes in our genome. So much higher resolution, and this one is becoming a standard of care also because of the decreased cost. Now, how are we doing? Not so great, unfortunately. That's the punchline. So we looked at this information in the Rhode Island Consortium for Autism Research and Treatment. This is a very large research study of autism participants back in Rhode Island and Brown University, which is where I was before coming here. And we had about 1,800 participants, and we wanted to look at the rate of adoption of genetic testing. So we know that the target to have these conversations is 100%. And I'm just going to pause here for a second because our professional obligation is not to do genetic testing, but to have the conversations about genetic testing with the families so that each of them can make the decision about testing or not based on their underlying values. So we should be having that conversation 100% of the time. Now, how frequently is that happening? Not so much. So the rate of testing back in this study was about only 3% of people receiving the standard of care 2 genetic tests. Those numbers were a little bit higher when you looked at each of the individual tests, but they didn't reach double-digit numbers. So we have a big gap between those professional recommendations and the standard clinical practice. So why is this not happening, and what can we do better? We decided to go to the most important place first, and that is to ask the families directly and the adults on the spectrum to try to understand a little bit better what their perceptions around autism causes and treatment and genetics knowledge and perceptions of chance and perceptions around autism and genetic testing and those genetic results were. So let's talk with the families who should have the final say in this area. We did a survey that we administered via electronic or paper version in English and in Spanish, and we had a tiered incentive for those who completed that. And we included people who had either a community diagnosis of autism or a positive ADOS. And we're looking at those data, but we had a relatively high rate of response based on kind of a longer and more complex survey. And we heard from the families that they had a very high interest in genetic testing around autism. They had familiarity with some basic genetic concepts, but not so much with the specific terms, which is also a sentiment that's echoed by several of our clinician colleagues. So this is not unique to the families. There's been a rapid evolution of genetic technologies. So there's a need for additional dissemination of knowledge comprehensively for families and clinical care. We saw that the majority of families reported not having been offered genetic testing by their medical team, and that for those who were offered genetic testing, 91% agreed. So this is really great in the sense that we're hearing directly from the families what their thoughts about genetic testing are and their interest in having that genetic testing done. And I'm also really happy that that number is 91% and not 100%, meaning that families are feeling confident that if they feel this is not what they want to pursue at this time, they can tell us about it and they can make well-informed decisions, again, based on their values. Now, for those who were tested, which was only a small proportion, we saw that 27% of them had an abnormal genetic result, which is what we were expecting based on previous data. Now, we used all of that information from that survey to think of implementation and dissemination science efforts to start addressing those barriers. So I kind of like to say that I am a silver lining type of person, and I love finding barriers because the alternative to that is not that there aren't any barriers, but there are barriers that you just don't know about. So with this one, we at least get some traction to try to facilitate some of those interventions. So we looked at all of those responses and we anchored them in this framework called the Consolidated Framework for Implementation Research. That is a helpful way of developing strategies and interventions in the clinic. And with that, we put in place several clinical services back at Bradley Hospital and Brown University, where I was, like a genetic counseling service that focuses specifically and exclusively on talking about genetic testing and carrying that out for individuals and families who were interested. Then we created a genomic psychiatry consultation service where we used genetic information for families who had an abnormal genetic result to inform psychiatric recommendations based on several of the things that we mentioned earlier. And I'm happy to expand on that at the questions time. We got, this is less relevant, gladly here in Canada, but we got support, administrative support for pre-authorizations for genetic testing, because that needs to happen in the US. But here in Canada, genetic testing is covered by healthcare, especially those 2 initial tests. That's part of the coverage by health insurance. And then we had some direct negotiation with genetic testing companies, which is less relevant here in Canada as well. And we also did an implementation of genetic testing as part of the inpatient hospitalization protocol at our child psychiatry hospital, because there was such a large gap, and we had kiddos who were being hospitalized for autism, and we had them there for about 2 weeks. Then this would be a good time to have these conversations and to try to catch up. This is an algorithm of how those clinical services look. And the idea is that we would enhance and empower clinicians as well to have those conversations with the families, or to collaborate with them so that we can help implement this genetic testing and support them in their primary care and family medicine trajectories. Now, based on those barriers, we came up with several solutions. We were able to focus on facilitating the conversation around genetic testing. So we heard that many of the clinicians in our community weren't fully comfortable having the conversations that would start the process of getting genetic testing done. So we developed a video both in English and in Spanish, and that we're translating to French now that we're here in Canada, and to Portuguese, where we cover the basic concepts around autism, genetics, and genetic testing in a friendly way, in a way that was co-developed with the autism community and with our colleagues in psychiatry and genetics, and in a way that's animated and also accessible for kids and adults with or without autism. We did several other interventions, like trying to move towards buccal swabs instead of blood draws to get those samples. We've streamlined the requisition process to get that genetic testing ordered. And we came up with strategies to deliver those abnormal results and to support family care docs and our child psychiatrists to deliver the normal results, exponentially advancing our goal towards implementing this standard of care. Now, this was a very successful strategy, and I'm happy to report that we are putting several of these strategies in place here in Edmonton and in Alberta, based on what we learned from the US ecosystem, and this has been going really well. And one of the things that makes this possible, and one of the crucial steps, is to, of course, work closely with the autism community, and this is of paramount importance for us as a team. And I'm happy to see several familiar faces here in the audience as well, because we want to help change that conversation. And I know we're only one of the many groups that is adding to the wonderful efforts towards changing those conversations. But we wanted to find ways of focusing on our shared humanity for people on the autism spectrum that does not come from a deficits-based perspective, but instead celebrates what makes us unique. So it's a little bit of a tangent from our content around genetics, but still very relevant. So we put together this campaign called "What's Your Thing?" This is one of my favorite questions to ask people in the clinic, because you get to hear about these amazing interests that are very deep and sometimes a little bit overwhelming, but there's so much richness and so much humanity that comes around learning of those. So we try to use that as an anchor point to acknowledge that we all have our very specific and deep interests, whether or not we're on the autism spectrum, and that could be a point of convergence. So we have launched several campaigns focusing on these, including one recent one with Positive Exposure, which is a fabulous photography nonprofit based in New York. We had the pleasure of having here in Edmonton already, and in close collaboration with our colleagues at the Autism Edmonton, we are we did this lovely photo shoot that focuses not only on recasting the way that people on the autism spectrum are presenting themselves to the world and being perceived by the world, but also focusing on these special interests and unique stories as a point of convergence. So I encourage you to look at this. And even though we're talking about genetics, I could not speak about this because it's one of my favorite things to do as part of these projects. So with all of these, we also developed resources for families and for adults, including our newsletters that cover several of the information that we've developed in a way that is accessible and amenable to be understood in people's native languages. So Spanish is my native language, and we had a huge Hispanic population back in the US. And we're doing that in French and in Portuguese here as well, to make sure that language is not a barrier to access some of these materials. And then this is a snippet of the video that we developed. So maybe I can show you 10 seconds because I know I have probably about a minute left. Let me see if this can go. And if not, we have a table outside and I'm happy to show you how that works. But again, it didn't go, but this is the Prisma Library of Life where we cover all of that content that I was alluding to. So with that, I think there's a lot of work to do in this space, and I'm very excited about the support of the community here and the close collaborations that we have with Lonnie and with the rest of the teams. This is a rich environment for this type of interventions, especially because of the shared goals that we've encountered with several of the groups that we work to. We are putting in place all of these interventions that I mentioned that we had developed in the US now here, and I'm excited to continue advancing and co-developing these clinical research and education proposals along with our partners in the hospital and the university, and most importantly, in the autism community. So thanks to everyone for making this happen.